I'd like to thank everybody for being involved in the hearing and all the work that goes into this as well. And you get a lot of thank yous from everybody who's up here. But I've been doing this for a while now. I think we've been doing this annual hearing and the report that goes along with it probably for maybe 6 to 8 years. And I've always been very close to it and supervising a lot of the work that goes into it. We collected an enormous amount of data from the health insurance carriers, in part for this hearing, in part for what we call our supplemental report, which characterizes the market. And we collect a lot of claims data from the carriers, too. And every year when we put together a potential agenda, there are always a lot of ideas about what we want to talk about, in addition to sort of the general overview of the healthcare costs and what's driving trends. And it's usually a pretty interesting conversation, and it's really challenging to narrow it down and keep sort of the scope appropriate for the audience we're going to have, come up with questions that the carriers can answer as honestly as possible, and get as much engagement as we can. I mean, we always want to kind of reach out to the provider community as much as others that may have a vested interest in whatever topic we have. But every year things change a little bit. We learn a little bit. We get a bunch of feedback from people. I'm not sure if it was mentioned, we've revised the report this year. The format's a little bit different. Hopefully it's a lot more digestible, and that probably won't be the last kind of iteration we have like it. But let us know what you think of what we put out there, what we produce, and if you have any suggestions for improvements in the future. It's very rewarding, though, to see it all come together, and first of all, for people to show up, the report to be produced, kind of the information that we're able to provide to be beneficial. And it takes a lot of people and a lot of work to make it all come together. So I just wanted to address that. Of course, you can't anticipate everything that might come up in the morning, and certainly could have avoided some things this morning, but so far so good. So I'm going to talk to you about the insurance department's latest iteration of the provider discount study. We've actually done this kind of analysis a couple times before, but we do make use of the claims data that are submitted by the insurance companies, and the statute that gives us the authority to do that is really focused on improving sort of the knowledge of employers and purchasers and providers and insurance companies about cost drivers and what's going on in our market. And this is one example of what we do with those claims data. So the first thing I'd like to start with is just why we're actually doing this kind of analysis. What's our purpose? And the short answer is to gain some insight about the competitiveness of our market. Every analysis has its limitations, but it does provide insight that's been helpful in the past, and it's been able to provide insight about what may happen in the future. We do spend a lot of time working with the New Hampshire legislature and other policymakers. We often see legislation introduced that's intended to improve the competition in our insurance marketplace. We spend a lot of time explaining how insurance markets work, and this type of analysis helps us a lot in doing that. So it's not a new analysis. As I mentioned, we've done it before. We produced reports in 2010 and in 2012, and those reports are actually available on our website. If you haven't been there, go to the insurance department's website. On the left side, there is a reports tab. If you click that, you can see the reports we've produced year by year, and you'll have to go back to 2010 and 2012 to see the analysis we did at that time. But they're up there, and there are a lot of other reports that we've produced either directly with in-house resources or using external contractors, a lot of them using the claims data, and a lot of them do provide insight about cost drivers and what's going on in our insurance markets. So I strongly encourage you to take a look at what we've got up there if you haven't already. The current analysis was performed by Barry Dunn under the direction of the insurance department. Basically, we started with Barry Dunn. Take a look at our last iteration of the report. Let's do something similar again and see what we've learned. All three of the analyses were done using what we refer to as the New Hampshire CHIS, the Comprehensive Health Information System, which is a robust claims database. It includes detailed claims that include what a provider charged, how much the insurer paid, what the member paid in forms of their cost sharing, as well as a lot of other detail about utilization and cost drivers. All anonymous data, so we can't tell who anybody is in there, but we can track changes over time, and we can look pretty closely at cost drivers. So why are discounts important? One of the first things that's important to realize about the way insurance works is that most of our premiums go out in terms of healthcare claims costs. So when we think about the competitiveness of our insurance market, it's very easy to assume that, geez, those insurers have tons of money. They must have lots of flexibility about what to do with all that money. But the reality is something a little bit different. If we imagine a world where two insurance companies are operating and everything is the same, in other words, their covered populations have the same healthcare needs, the benefit designs are the same, cost sharing is the same, their networks are the same, everything is the same except what they pay for healthcare services. And the discounts lend some insight into that. And you can see that in this example, carrier B pays about 12% more on average for their healthcare services than carrier A. Because carriers need to spend under the ACA 80 to 85% of the premiums on medical claims costs, and they usually spend a little more than that. Typically, the average is close to around 13%. There's so little that they retain to make up for competitive deficiencies that they might have, such as if they're paying for healthcare claims costs at a higher level. And so if the premium is set at the red bar that goes up and down, the horizontal bars are how much is spent in medical claims. You can see the difference in the outcome for each of these carriers. It's a 5% loss for the one on top, carrier B, and it turns out to be a 5% profit for the one on carrier A. Again, just a 12% difference in what they're paying for claims. And if you look at the note down at the bottom, an example of a 12% difference in payments to providers might be a 40% discount versus a 33% discount. So again, everything being equal, which is normally the reality, but the discounts provide some insight about what carriers are paying and how they compare to each other. So like I said, we did these analyses a few years ago, and so we have some knowledge that we have based prior discussions and conversations with the legislature as well as other policymakers on. And this dynamic, this graph, is one that probably a lot of you have already seen, but it's worth revisiting, because I think it does share kind of what we've learned about discounts and market share. So this was the PPO product line using 2011 data, and it was produced in the last version of the report. And so when you look at the red bars, those are the average discounts that each of the carriers got with healthcare providers for PPO. At the time, there was a big difference between what PPO reimbursement was and HMO, at least with some carriers. HMO tended to be the most aggressive, in other words, the deepest discounts. But we tried to keep things as comparable as possible. And you can see that the big three, the one everybody's familiar with, Anthem, Cigna, and Harvard, all had the deepest discounts. You can also see the blue bars being a proxy for market share. Those are also the three carriers that carry the most weight in their negotiations with the healthcare providers because they had the greatest number of members that they could potentially shift to another provider. You can see that in some cases, even national giants like Aetna, who don't have much of a presence in New Hampshire, weren't able to get the same level of discounts. And that's largely true still today. You can also see that MVP, since left our market, was not really competitive with the big three, and certainly their provider contracts may have contributed to the reasons they had to leave the New Hampshire market. New Hampshire Health Plan was just a high-risk pool, which operated at the time. Anytime you do an analysis, there are always limitations, and people love to point them out, particularly when the facts don't support the position that they'd prefer to be in. So some of the limitations in doing a study like this, and in New Hampshire we can probably do it, and when other states can't, but there's still sort of limitations we have to watch out for. The first is carrier market share by hospital varies. It can vary some, it could vary a lot. And if you're dealing with a different amount of market share, it's going to weight the overall discount differently. And of course, the hospital charges aren't standardized, so one discount at one hospital isn't necessarily equivalent to the discount at another hospital. Clearly, the networks may vary. New Hampshire tends to have a more robust set of provider networks than what you see in a lot of other states. But that is also a consideration and potentially a confounder. And then, of course, provider contracts may differ in ways that can't be detected by the claims data. So claims data may represent sort of interim payment, and there may be some sort of incentive payment at the end or even a kind of a risk reduction. One of the other limitations is that prescription drug costs weren't included in this analysis, and they weren't included in the prior analysis. So when we think about sort of carrier competitiveness in the market, prescription drug costs are often 20% of the premium, so it's certainly a larger piece to leave out. But again, we're just trying to get insight about what's going on in our markets. The other elephant in the room is that the claims data are historical, so it represents the past. It doesn't necessarily represent today's world or the future. It's a little like driving with your rearview mirror. I mean, it's better than nothing, but you got to be careful where you're going. And then, of course, Overall discounts could be influenced by deep discounts with large hospitals. So if an insurance company made it a point to get a really good contract with the largest players in the state, at least really good compared to the competitors, that's going to influence their discounts, and maybe a different story with other providers. And one of the other sort of notes of caution in looking at these kinds of results is that they're not highly suitable for employers to use. So if you've got a self-insured employer operating in the Seacoast and you're looking at whatever carrier appears to have a great discount, that may not represent the discount that that carrier has with the Seacoast hospitals where your members, your employees, are going to end up going. So just a word of caution. It's very useful from a high-level policymaker, insurance regulator perspective, but we wouldn't encourage an employer to use these data, at least not from the findings we're producing. Okay, so before you do the analysis, you know there's going to be limitations, you know there's going to be certain risks. We wanted to check a number of things, and we did that, or Barry Dunn did it for us. And to make sure they weren't going to be, again, confounders that would throw our findings off. And the first one goes to the fact that historically carriers would sometimes pay a healthcare provider more for their self-insured accounts in order to get a deeper discount for their fully insured business. And there have been representations that doesn't exist anymore today, although some folks still believe it does. We did look at the claims data, and if it exists, it's not substantial enough to throw our results. So whenever you're doing an analysis like this, you have to make decisions about whether or not you combine data and just aggregate it, and you deal with sort of the results and the findings at an aggregate level, or you start to split the data and say, well, for this population or this pool, the answer was this, and then for this one, it was this, and they might be different, but anytime you start to split the data, you deal with more variability. And so in other words, you just deal with smaller numbers. So the differences you're looking at might not be real. They just might be new normal variation. You're always better off aggregating data as much as possible, as long as you don't believe that there are underlying differences. It's sort of like when you think about a survey, you know, the more people that are involved in the survey, the better your information is likely to be, or at least a higher response rate. Like I said, historically, there used to be different reimbursement levels depending on whether or not the product was considered an HMO product, a point of service, or a PPO. We took a look at that, and despite that last iteration of the report, which there definitely were differences in 2011, they don't seem to be at least substantial enough to still be relevant today. We also looked at that question about market share or use of the different hospitals, the distribution of a carrier's use of different hospitals, and that also was similar enough not to be a concern in the analysis. Finally, these are claims data, and anybody who's used claims data knows you see a lot of funny things in claims data. Just what's going on here? Don't know. Okay, well, does it happen often enough it's going to be a problem? You have to make a judgment decision about that. We have a lot of different ways of paying healthcare providers. Discount from charges is nice and straightforward. We've got DRGs that pay on a per case. We may have per diems. Who knows? Maybe we even got episode-type treatment methodologies. We're telling carriers how to submit the data using fields that exist on one of two standardized claims forms. A carrier could submit data incorrectly to us because they're paying on a DRG and they didn't quite read the rule correctly or didn't understand it the same way. So we looked for those kinds of variations, things in the data would throw our results. And indeed, we actually found one of the carriers that was not reporting their DRG-based payment the way we expected. We were able to work around it and get the carrier to submit their data correctly going forward. But it was something that Barry Dunn spent some time looking into, and it's always necessary whenever you do an analysis using the claims data. And just because it didn't exist a year ago doesn't mean it doesn't exist now. So you always have to do it every time you do an analysis like this. So what was the strategy for the current analysis? We knew going into this that the reimbursement rates to providers were likely to be different between the individual and group markets. So we'd separate the results by individual and group markets. Indeed, the competition in each of those markets is a little bit different, the players, the carriers. We would include as many carriers as possible, including some of those who have left the market. We have noticed over the years that the carriers without competitive discounts tend to struggle on an ongoing basis. And whether or not that's the only reason they leave the market, well, probably not, but it may have been a contributor. Since we haven't done this for a while, we also thought it'd be helpful to look at a few years worth of data and see how things have changed. When Barry Dunn ran the analysis, we used the most complete data we could in 2017, but it was just through October. So some of the data I'm going to show you is for calendar year 2016, seeing that it would be an advantage to use a calendar year's worth of data rather than just the 10 months. We also decided to break down services into broad categories to better understand how those discounts flow through from different provider groups. All right, a lot of background. Now I'll jump to the results. Looking at the group market, this is what it looks like. So going from left to right, you've got the health insurance carrier. You've got each year, 2015 and 16 are each calendar years of data. Then you've got that January through October of 2017. Finally, in the final column, you've got the aggregate allowed amount of dollars. So it's a little bit of a proxy for market share, and but of course it is over more than a year. But it also gives you a sense of potentially how much weight each of these carriers have in their negotiations with providers. You can see Anthem is in a very strong position in the group market. And looking at 2017 with an average discount of 48%. As you go from there, Harvard's in second, but a 4 percentage point difference is substantial. Cigna and Tufts are pretty close at 42%. Aetna tails a little bit behind at 38%. United 34%. Minuteman, no longer in the market, 41%. Overall average of 45% in 2017, just during the year of data we looked at. If you looked back at the prior years, there are some differences. There are some changes among the carriers and among the years. You do see an increasing average discount looking at each of those years. That doesn't necessarily mean that the carriers are paying providers less. It's, remember, discount is going to be a ratio. So to the extent charges are going up, payments may just not have gone up as quickly. So you end up with what looks like a deeper discount by year. And for those who benefit from a visual demonstration, this is basically the prior chart shown visually. So again, you've got Anthem all the way to the left. That line that goes down through is the proxy for market share. And you can see how they compare to each other. But you can see that there is definitely an association between how much market share, how much bargaining power the carrier has, and then, of course, their ability to extract a better discount over time. And you can see Minuteman all the way to the right, relatively small market share, particularly in the group market. And but their discount looked a little better than United Healthcare or Aetna. Looking at the individual market, we thought that discounts might be deeper, and indeed the data proved that to be the case. We see, though, that Anthem is again in a strong position in the individual market. We do see, though, that Ambetter is pretty close, or I would consider equivalent. Remember, there's always going to be a little bit of noise in these numbers, so 1 percentage point difference may not be sort of real. I mean, to the extent we're looking at some of the reasons for some noise or some variation. But Anthem and Ambetter, very close in 2017. Again, pretty close in the prior year as well. Harvard, again, behind Anthem. And then Minuteman, pretty close to Harvard, but still what appears to be a bit of a disadvantage. And again, when you look at all individual policies, you look at the discounts over time, you do see an increasing discount from charges, but again, doesn't necessarily mean that the carriers are paying the providers less. In fact, that's most likely not the case. When you look at the display graphically, you can see a similar relationship to the group market. However, you do see that Ambetter, despite having a lower market share, and again, this is commercial market, does seem to have that discount that's competitive with Anthem. Remember, they're also in the managed care side of things for Medicaid. So when they're negotiating, when they're thinking about network development, they're putting together contracts. They are negotiating for more than their individual commercial population. And as we think about insurance and this type of analysis in the prior years, it's certainly been relevant when an insurance company offers more than just the product. Clearly, it may have different terms depending on the type of product, but overall, the contract negotiations, decisions about reimbursement levels are being done at the same time. So again, looking at 2016, not 2017, we're just talking about 2017, but the group market, and when you start to split the types of reimbursement to what type of healthcare provider it is, these are how the breakdowns take place. And I think it's, again, I mean, physicians' charges aren't going to be equivalent to a hospital, but to the extent the carriers differ, that's what's going to be more important. So if we're looking at Anthem, again, strong position 2016. They have a particularly strong position when you look at discounts for professional providers at 51%. And that compares to, as you can see, the other carriers as you go down the spectrum. Things change a little bit depending on whether you're looking at hospital inpatient or outpatient. Other facilities up there, although it's a much smaller percentage of the total dollars, and the all services is just the overall discount. And you can see how things play out among the carriers and among the types of service. If you're looking at the 2016 individual market, a similar story, just deeper discounts and fewer carriers. Community health options is also listed on there with Minuteman, even though, again, they're not in the markets, but you can see how they compared while they were in the market in 2016. So where do we go from here? As I mentioned, we've done the kind of analysis before. We'll summarize the findings, include them in the general cost report. Remember, what we've published so far is a preliminary report. That has to do with we're supposed to produce a report by November 1st, and so we produce a preliminary report. We have the hearing, may include information from that, and then we produce a final report. Also gives us a chance to receive comments from people who attended the hearing. Certainly we can consider that kind of information as well. These slides, or some of them, may be used during testimony and presentations with the legislature or other policymakers, the public. And I recognize a lot of you, so a lot of you know I'm giving those kinds of presentations and testimony. And it's very helpful, again, for explaining how insurance markets work. We often have at least the perception that if New Hampshire had 10 insurance companies, all with equal market share, so say 10% of the market, that our health insurance premiums would be less expensive than they are today. This kind of analysis demonstrates that if all the carriers were getting the same kind of discount that Aetna did, we'd probably be more likely paying more for our health insurance premiums. So it's very important to understand how our markets work, and New Hampshire's not unique in this context. About 99% of markets across the country are dominated by 2 or 3 carriers, and obviously has a lot to do with network development. The analysis may be updated annually and included as a part of the hearing in the report. We have a specific statute that calls for the insurance department to do this hearing and produce the report. It includes a requirement to do analyses that are very much consistent with the discount study. It obviously, like I said, has its limitations, but it does provide some insight into what we know about our markets and the way insurance works. So it's brief. I know I spent more time on the background, but anyway, I'm happy to take questions and go from here. Paula.
Thank you, Tyler. Clarification on the individual market. Does that include the health protection plan, Medicaid expansion data, or not?
It would that was 2016. So yeah, to clarify for everybody's benefit, you've got a Medicaid population, the expansion population that is in the commercial market. So DHHS is essentially a purchaser of commercial health insurance, and the reimbursement terms should be the same or similar for that population because, again, it's a commercial population. It would be different than potentially the managed care organizations administering the benefits and contracts purely for their traditional Medicaid coverage.
Add a caveat to that, though, because from the provider perspective, and for those that don't know me, I represent the Hospital Association, there was a caveat relative to Medicaid expansion when that was approved by CMS that required reimbursement rates to be a certain level, which are more related to Medicare. And so I think that, honestly, I would argue skews that data. So it's going to be out starting in 19, but I think it could skew the data.
So to repeat back to you, you think that the discount would be lower without that term in there or higher?
It's going to skew it. However, I mean, I don't know the different, negotiations obviously, but it's very specific that it's more Medicare related rates for that population. which, and you don't have the rest of the Medicaid population in there. I believe it skews. There are other hospital contracting folks here that may or may not agree with me, but I think it skews the data.
I understand. Thank you.
That's all.
Lucy?
You may have answered this when I was out, and I apologize.
Sure.
So these are discounts off of charges.
Yes. Yep.
How do you account for the different, charges, such a random price point? Did you ever consider doing it as compared to the Medicare as a?
Oh, wow. Yeah, so the big question of that is making sure that we've got kind of a similar distribution, at least among the hospitals. It's sort of funny when you look at how an insurance company distributes its payments across the system, and you'll find that every provider is such a small percentage of the total. It gets so diluted in terms of the impact. It's kind of, but that's really one of the things you need to watch for most. In other words, if Anthem sent all their business to one part of the state and Harvard had all of it going to a completely different system, those two system charges would be most likely different, even in aggregate, and so one discount wouldn't be equivalent to the other. So that's essentially the way it was done. Looking at sort of a percentage about Medicare is an interesting idea on a scale at this level of scale, because you'd be looking at more than professional reimbursement. You'd be looking at hospital reimbursement, inpatient and outpatient. You'd be looking at other kinds of providers. I will tell you that the department has done additional analysis at the professional fee schedule level, and we do see some consistency in the findings between what's been presented here and some of those other analyses. Those other analyses were done for a very different purpose, but it's still interesting, and the approach to that was looking at sort of a Medicare plus % amount. Yeah. Any other questions?
Yes, I would
I'm sorry.
the comment. We're talking about the insurance discounts and how they need that to, continue to provide service and coverage and blah, blah, blah. But, providers go years sometimes without going up on their rates, or they don't do the cost of living rates or anything, yet the carriers are consistently dropping their reimbursement. Now, mind you, every year we have different requirements that go into us providing that care, and we're still supposed to do it under the constraints of that same little payment, and they're kind of making their own rules. And when you ask for the transparency, how are you coming up with this is based on Medicare and the marketplace when I can't get them to give me that information? Like, show me the dollars and cents, because when I send you the Medicaid rates, and you are paying under Medicaid rates, that does not tell me that you're using those to find what our reimbursement should be. And when I get a reimbursement form from a patient, and it stipulates on it, this is how much you saved, it makes the provider look like we are way overcharging and gouging the patient when we're literally getting $600 or $800 for doing a surgical procedure under sedation. And that patient thinks that we're overcharging. What about the carriers actually working with the providers? We're supposed to be trying to work for the same goal, but it doesn't feel like that's what's occurring.
Thanks for the comment. And this is actually a hearing, and we do dedicate the last portion of the hearing to comments. But thanks for your contribution. So at this point, let's stick with questions, and then we'll transition into the comment period and open it up.
I know it's a small number at this point, but does your data include the Medicare Advantage plans?
Yeah, good question. So Medicare Advantage is not regulated at the state level, and it does not include the Medicare Advantage data. Yep. All right, unless there are any other questions, I'll pass it back to John. We can open it up for any public comments.
As Tyler mentioned, we're going to move now into public comments. So if you would, So if you would like to make a comment, please identify yourself and speak into the microphone.
I'm
Sharon Beatty with Mid-State Development Corp. in Plymouth and Bristol. I just would like to say that the quality of what's on the website and the accessibility and the relevance to our patient and the reading level of all that has improved dramatically, and I know it's taken a huge amount of work, and I thank you for my patience.
Thank you very much. Anybody else?
Can I just ask a follow-up question? Which website and which part of it are you talking about?
All the information they have for the patients about how to evaluate a plan you're looking at, what you should be mindful of, where to call if you need help, that kind of information for the consumer is just amazingly good.
On health costs or on the NHID website?
On the NHID website. Sorry, Tyler. I apologize.
Anybody else? All right, well, thank you all for attending. I think there was a lot of great information. We're going to be publishing some reports in early December, as I mentioned, and we actually we'll have written comments will be accepted up until November 13th, so that gives a couple weeks. There you go. So, thank you again.